Welcome to Conference Highlights, recorded in front of a live audience at an evidence-based perioperative medicine, that's EBPOM conference. EBPOM are world leaders in perioperative education, so why not join us at our next meeting with a special discount for Top Med Talk subscribers. Look us up on www.ebpom, that's EBPOM.com. Top Med Talk.
Tony Senagore, colorectal surgery, tie. Our ties are cleaner than where we work, so we still wear ties. I just wanted to start off with one just quick story about enhanced recovery because I've been doing this for a long time. And sometimes just stepping back and looking at a problem and trying to figure out what drives the problem is a good way to fix it. And the example I'm going to use is the U.S. Navy. At the end of World War II, they recognized carriers were going to be the weapon of the future for the Navy. And the admirals got tired of planes crashing into the conning tower. That's that thing that sticks up on a World War II aircraft carrier. And so they had all kinds of designs, and they actually had a design where that whole thing would go up and down during flight operations. You can imagine that's probably pretty complex. So they're getting ready to make design decisions, and a lieutenant that's on the design team says, you know, if there's a problem with them crashing here, why don't we just have a place that they land that goes this direction? So if you'll notice now, every modern carrier has a thing that goes off this way, unlike a U.S. carrier that's a rectangle. That was a whole lot cheaper solution and actually a lot safer and improved flight operations by 45% from 1945 to 1950. So just sometimes something simple can have a huge advantage. So potential new components are this. I'm not going to talk about anemia, except to say that we have developed a reflex testing where I order a CBC. If they're anemic, reflex testing identifies iron deficiency anemia, and I can one-click to infusion for my iron-deficient patients. So it really is an efficient thing. I know there are several talks about anemia, and I'm not going to belabor that part. The last thing, goal-directed fluid management. Again, I think a lot of this is just common sense. There are various sessions at this meeting that are going to do a much better job, so I'm not going to touch those two things, but I am an advocate. What's not new? In my world, bowel prep with oral antibiotics, yeah, Nichols and Conner were correct 20 to 30 years ago, actually 40 years ago now, and it's still true today. IV prophylaxis, DVT prophylaxis, all this stuff should just be part of your normal care plan. None of this should be debated. So my version of a simplified enhanced recovery program is this. What I think the new things are in red, the glycemic control, preemptive oral analgesia. You can see my oral narcotic-sparing regimen, and I'll talk to you about the science of why I choose that. Let's change gears now. So the last 3 prospective randomized trials of colorectal surgery for immunonutrition all failed to make a difference. And the reason is our patients are not malnourished, by and large, in the U.S. at least. They're actually sarcopenic. This has actually been rife in the surgical literature, that if you're old on a CT scan, you're just old. And it really ties to overall outcome. Across all surgical procedures, if you're sarcopenic, it's an issue. The problem is this physiology is very distinct from all of the typical nutritional supplements that we've been taught to use. They typically include things that have all failed. Arginine failed in prospective randomized trials. Glutamine failed in prospective randomized trials. Omega-3 fatty acids, not sure that makes a difference in prospective randomized trials. You have to go to some other literature source. This unfortunately comes from the geriatric world, and you don't have to read the whole thing. But this is the largest study actually internationally on sarcopenia, and what it shows is what the science actually dictates. You need leucine as the amino acid, you need vitamin D and vitamin K2 if you want to change the physiology of a sarcopenic patient. You won't change it with arginine, you won't change it with simple sugars, you won't change it with the other amino acids. And that's why all the other studies have failed to make a difference. So unfortunately, now we're at a point in enhanced recovery where you actually have to go back to that biochemistry and physiology stuff and start to revisit some of these pathways. Same with hyperglycemia. If you look at the literature, almost every surgical procedure has a paper that talks about the negative impact of hyperglycemia, particularly in non-diabetic patients. They fare much worse. And the reason is that acute onset of stress-induced hyperglycemia sets off a whole pattern of physiology that impairs cardiac function, impairs arginine ADMA functionality for endothelial function, and also increases liver gluconeogenesis. None of that is good physiology. These are the potential carb-loading solutions. The problem is this is the quintessential study on those 50-gram products. This is the ProSci study, is the acronym. This was in Europe. And what it showed is it did not sufficiently decrease the rate of post-op hyperglycemia to make a difference in outcome. And the reason is it's simply too much sugar. There was a induction of hyperglycemia with this dose on the morning of surgery. Average glucose level was around 160 to 180 in non-diabetics, and a 25% population rate of hyperglycemic variability post-op, so the complications didn't change. Giving a lower dose did show. This is one paper looking at a half dose of that, 25 grams, that also provided citrulline. And this dramatically decreased the glycemic variance to 7%. Not an outcome-based study, but again, a surrogate measure that shows that the hyperglycemia rate can be positively impacted by changing the strategy that you replete it with. Talk a little bit about arginine bioavailability. This has been looked at a long time, well before even I entered medicine. But almost every study looking at arginine supplementation has failed, particularly enterally. If you take it by mouth, 50 to 60%, if you're just normal, is degraded on the first pass through the liver, so it does not provide systemic arginine. If you're sick, you actually degrade 80 to 90% of it because you have an increased arginase activity in your liver. So giving arginine has really never been successful in almost any model, and in fact, in the cardiac world, has been detrimental. So how do you get there? Citrulline is a much better amino acid. There's no apparent toxicity that's ever been documented for wide-ranging doses. And it's kind of an eye chart, so you don't have to read it, but all of the downstream functionality of providing systemic arginine is manifested by the breakdown of the arginine products, proline, ornithine in particular. And so when you look at how to supplement this, citrulline is almost 100% absorbed in the GI tract, almost 100% converted to arginine in the kidney. So you get essentially 100% supplementation of systemic arginine with this approach. So it's a lot safer way to get there and a lot easier way to provide that drive. This is looking at the drop. This is a laparoscopic colectomy, so more modest surgical intervention. Shows a 20% drop in the arginine-ADMA ratio. This ratio drives systemically the availability of arginine and is a surrogate measure for endothelial function. So it's been pretty well worked out in critical care, been worked out in cardiology to a larger degree, but this drop in a ratio is a negative factor. It does reverse over time, but it is significant, and the bigger the operation, the bigger the drop. And again, if you give arginine, you don't get the systemic arginine, and you actually increase ADMA, so you actually narrow the ratio more. It really isn't an effective strategy. This is a cardiac surgery paper, but it shows that when this ratio drops, overall cardiovascular complications increase and infectious complications increase. Why? Because arginine is not bioavailable in this population because of the stress response. This troponism thing, so that's something you anesthesia folks understand better than us surgeons. If you believe it exists and believe it happens, it does seem to be detrimental. This is another manifestation of endothelial dysfunction. It really isn't direct cardiac injury in the classic sense, at least, but it does imply cardiac dysfunction because of the same narrowing of this post-op ratio. Same with AKI. There are now 3 recent colorectal papers that show an increase in AKI. I'm glad we fixed it in cardiac surgery. We might have to learn something. But again, this isn't a fluid management issue. I mean, a lot of these papers came from places that were doing goal-directed treatment and were effectively managing it. This is a residual dysfunction, again, related to endothelial dysfunction post-op that can't be circumvented by how good or bad you are with fluid management. I'm going to blow through this. So let's talk about pain management. So we all know the misadventures of poor pain control, and I think we underestimate what that is. A lot of the migration to chronic pain management are in patients that have poor acute management. Escalated dosing narcotics, but poor management. So I got the high science, so I'm going to have to give you some quick science here. This is why they don't work, and this is why EMEND is a challenge in bariatric surgery. EMEND drives actually several of these genes, so you're going to get much degraded function of your narcotics. And I'm just going to hopefully show you. We're just going to stop here. People switch to celecoxib as a choice. The FDA actually has a black box. If you have one of these mutations, celecoxib is actually dangerous, not safer. But urban legend would say celecoxib is a much safer NSAID. So you have to be really careful when you look at some of these things to look at the science. And I would submit when you look at your complications, you need to try to find the driver of that complication and go back to some of the science because not all of it is clear in the literature right now. But thank you.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube, and make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. ebpom.org/meetings.